I am going to start this morning with a very short introduction to the COVID-19 inquiry. I'm sure there probably isn't anyone in this room today that hasn't heard of the inquiry. There are probably many different views among you around the inquiry, its purpose, will it actually achieve anything, and what does it all mean? So I'm going to bring a broad perspective only to the inquiry, and I'm going to talk to you through the lens of nursing practice and the role that the Royal College of Nursing played within that. So, to start, the purpose of an inquiry. So there have been many inquiries, but essentially an inquiry is there to establish facts about what happened and decisions that were made that influenced the experience at the time. The inquiry is about learning. So Baroness Hallett, who is the chair of the COVID-19 inquiry, is very clear that this is about learning, and that learning will enable us to hopefully be more resilient for future events, to understand what went well, what didn't go so well, and also to really reflect on the experience of society in the whole. So this inquiry is not purely focused on infection prevention and control. Infection prevention and control is a key element of it, but it's not everything to the inquiry. There are many people involved as core participants, which I'll come on to in a bit, around the inquiry, and the purpose of an inquiry is also to allow catharsis of the experience. So it allows people to be heard in relation to their experience. And there are many bereaved families and bereaved groups that are represented at the inquiry to allow for that. There are a number of inquiries underway at the moment. Some of these will be familiar to you, perhaps some of them not so much. Oops. Sorry, can we go back? Thank you. So the COVID-19 inquiry is going on at the moment, and these are inquiries where the Royal College is engaged currently. Alongside the UK COVID inquiry, we've been supporting the Scottish COVID-19 inquiry, the Thirlwall inquiry, which was around events at the Countess of Chester Hospital following the conviction of Lucy Letby, Muckamore Abbey in Northern Ireland, the Lampard inquiry around deaths in mental health institutions in Essex, and the infected blood inquiry. So the legal team have been really busy for a period of time. The Scottish Hospitals inquiry, which is absolutely relevant to infection prevention and control, has also been underway, but we haven't been a core part of that inquiry as an organisation, but of course we will have supported members that have been involved in that. So the approach that Baroness Hallett has taken to the inquiry is one of a modular approach, which has looked at various aspects of the COVID-19 inquiry in order. And in bold and italics there are the three that I have been involved with to date. Some organisations are involved in all of these, others in one or two or more. So we have just finished Module 5, procurement, and Module 6, the care sector, and test and trace and isolate will be starting soon. The inquiry should finish around the end of next year, and there is a commitment to release interim reports after each module rather than to wait to the end of the inquiry, because learning and implementing learning is absolutely critical. So this slide here outlines the main stages of the inquiry as set out in the terms of reference. It's around evidence collection, it's around oral hearings where more information is requested, and then finally around closure and publication of the report, hopefully at the end of next year. So, what are the inquiry's powers? And what does it actually mean in terms of gathering evidence? Sorry, can you go back? Thank you. So, the inquiry needs to fulfil its mandate, and in order to fulfil the mandate, the inquiry needs to gather evidence from a huge variety of sources. The inquiry can issue what's called a Rule 9 request, which is where information is requested from individuals, from organisations, or from other entities to respond to questions and provide evidence that the inquiry wants to hear. It is a significantly onerous undertaking, and when you participate and respond to a Rule 9 request, you do so by consent. The inquiry has significant powers to compel written and oral evidence, and if required, it can do so. The timescales for submitting written evidence are very tight, and there are often a lot of toing and froing and further questioning that goes on before a statement is finally written. And then, depending on the information included within that, you may or may not be called as an individual or as an organisation to contribute to oral evidence. We have an RCN inquiry team. Sorry, can you go back? Apologies. We have an RCN inquiry team that has been supporting the various people within the organisation that have been required to support Rule 9 requests or indeed to give oral evidence. And they have reviewed over 30,000 documents, but in fact we have pulled over 100,000 documents across the organisation to support the inquiry to date. And that involves a number of teams, including our archive team and others. So it's not an insignificant undertaking. The teams support the drafting and development of statements. They also attend the daily hearings and the preliminary hearings, and we have a daily report that summarises just some of the key points afterwards. Very early on, the RCN developed a dedicated web page because a key part of the inquiry is around allowing people's experiences to be heard across the country. This pandemic and the experience of healthcare professionals was unique because every single person was affected by COVID-19. Whether you got COVID-19 or didn't get COVID-19, everyone was subjected to lockdown restrictions. There were decisions around vaccinations. We all had loved ones that we cared about. Some of us lost loved ones during the COVID-19 pandemic. And for health and care professionals, they were working during the pandemic in a variety of roles that had a significant impact on the delivery of care and patient care in all care settings. So this inquiry is very, very personal to many, many people, and the inquiry has allowed people to give their experiences, and I have details of how you can do that if you still wish to at the end of the presentation. But we have a dedicated webpage that promotes that to RCN members, and we provided many frequently asked questions and resources such as that to members, but also to our regional teams. The Royal College of Nursing applied and was granted status as a core participant for Module 3. And if you are a core participant in the inquiry, it's a different experience to being requested to submit evidence, which was the case for Modules 1 and Module 5. So a core participant plays a key role in the inquiry process. You are privy to information and witness statements before people give evidence, and you have the opportunity to ask questions, to propose questions to those giving evidence in oral hearings. So it's a very different and increasingly onerous experience, but one that is very worthwhile if you have a particular interest in a particular module. And for us, it was module 3, which was around the impact on health and care services. So that was really important to our 550,000 members that contributed during the pandemic. And it's very different, as I said, to being a witness. So just to summarise very quickly, Module 1 was around resilience. The organisation was not a core participant, but we were issued with a Rule 9 and subsequently asked to provide oral evidence. And Baroness Hallett has published the interim report from Module 1, which is available on the inquiry website. And these are just some headlines from the Module 1 report. I would urge you to read it if you haven't read it already, and to think about what that means in relation to your role. Obviously, we need the final report, but these are the key headlines so far, some of which won't be a surprise, but the legal teams supporting the inquiry actually are really to be admired as non-experts in this field in taking a huge number of documents and some very complex issues and summarising and drilling them down to a report and a set of recommendations. So why were we invited to contribute to Module 1? Well, this is around preparedness and the ability to respond, and therefore the nursing workforce, as the largest part of the health and care workforce, is absolutely critical to any response to a national or international incident. We also had significant experience of supporting a range of incidents going back to and beyond the swine flu pandemic in 2009, and there had been significant learning from swine flu and from Ebola and from the MERS management in Saudi Arabia that we were able to contribute prior to the pandemic. So this was really about understanding the experience of nursing, how we were involved, whether it was infection prevention and control or other aspects of professional nursing, in preparedness, and how advice and learning from previous incidents had been implemented or not. And a key part of that was around the inquiry compelling the release of evidence in relation to that. Module 3, as I said before, was very broad, and the themes that we focused on were very much relevant to nursing practice in all care settings, but predominantly hospital settings, of which infection and prevention and control was one part. So the inquiry wanted to hear about the role of the college and to understand its dual role as a trade union and as a professional Royal College, which is very different to that of the medical Royal Colleges. It wanted to understand around the development of infection prevention and control guidance and why there was challenge at different points during the pandemic around the guidance that was issued at the national level. The supply and distribution and use of personal protective equipment is a theme that has run throughout many of the modules, and this was core to Module 3, but also to Module 5 in relation to procurement. And the inquiry wanted to know about our experience and the experience of our members in relation to that, and how the requirements of COSH and the Health and Safety at Work Act were met in practice. They also wanted to look in detail at data around infections and RIDDOR reporting to the Health and Safety Executive to understand how infections and their impact were monitored. Module 5 has just finished, and the focus of Module 5 was on procurement. Many of the themes from Module 3 were repeated for Module 5, but a more in-depth review of how nursing contributed to the clinical evaluation and understanding of the clinical effectiveness of the personal protective equipment that was provided. So what worked well, what didn't work well, and how could we do better in the future? The learning from the inquiry is huge, and this is really a seminal moment for infection prevention and control. And I've worked in infection prevention and control for many years, and I've had the privilege actually of seeing, observing, or being part of a number of incidents. The last seminal moment for me was back in 2006 following the outbreaks of Clostridium difficile, which ultimately resulted, because it coincided with changes taking place in legislation at the time, with the creation and implementation of the Code of Practice that many of you will be familiar with. Before the outbreaks of Clostridium difficile, we did not have a Code of Practice to which healthcare providers were regulated against in relation to infection prevention and control. So that was a seminal moment now. The seminal moment now is around learning and really, for me, reflecting on the context of infection prevention and control and the impact that our decisions have, not just on our immediate patients, but actually that ripple effect throughout society when decisions are made that impinge on individuals' rights, on the economy and other aspects. And many of these decisions, of course, are political decisions. They are not the decisions of infection prevention and control practitioners, but the science and the implementation filters through at the local level. It is absolutely about understanding the impact on healthcare workers and how we can develop PPE that is different in the future, that is effective and protects our healthcare workers. It's about understanding the psychological effect on the bereaved and for those that weren't able to be with their loved ones when they died. And this is reflective of many, many countries. It's also very sobering in terms of understanding how healthcare workers can be perceived by the public. And the really stark image there on the right-hand side is truly shocking, where people are accused of having blood on their hands. But this pandemic was very different to other pandemics because we had social media. We did not have the extent of social media in previous incidents, and that can be an extremely harmful issue to have to contend with, as well as having benefits. So how can the pandemic change attitudes and actions? Well, no one will be held guilty or not guilty of anything as a result of this inquiry. No one will be charged with anything. It is absolutely about learning. But as I said before, it is a real opportunity for infection prevention and control to reflect and learn and evolve. And I would really, at this moment, like to acknowledge the huge contribution that infection prevention and control practitioners made throughout the pandemic. I don't feel that that contribution has perhaps really been recognised, with a lot of focus on what's called frontline nursing, which is a term I find uncomfortable. Actually, there were many nurses working, supporting those delivering care that had extremely difficult and challenging experiences during the pandemic. So I just want to acknowledge the role that infection prevention and control practitioners made. There's been significant challenges and changes in how we deliver care, and that is going to continue to evolve. And infection prevention and control has to fit with those changes. So it's about the constant evolution and adaptation. It's not about rigour of black and white. It is also an opportunity, and you're here tomorrow, to think differently about some of the ways we have considered the transmission of infection historically. And I truly believe it's the biggest opportunity we've had for many, many years to encourage people into infection prevention and control, to succession plan, and to take the speciality into the next 10 to 20 years. So finally, what can you do as an individual that was personally involved in the pandemic or who experienced the pandemic, because I'm aware that not everybody in the room is a health and care professional per se. Well, if you're an RCM member, and if you're not, you can go onto the inquiry website and you can contribute to Every Story Matters, which is a listening exercise and allows you to tell your story, and the inquiry is reading every single one of those.